I would like to invite Dr. Jay Richards up, who will be moderating our first panel. He's got a very impressive resume, so I'll be brief. He's the director of the Richard and Helen DeVos Center, and he's also the William E. Simon Senior Research Fellow in American Principles and Public Policy at the Heritage Foundation. So I'll leave it to you, Jay.
Well, it's a delight to be with you all. And so there's some of us in the room that were at a Detransitioners Awareness rally 2 years ago, almost to the day, in front of the state capitol in Sacramento. And the Capitol Police had to create a massive partition to, honestly, to keep everyone safe. We have come a very, very long way in 2 years. It's absolutely amazing. And the fact that we're here in the Capitol and that people are listening to us, that there have been executive orders specifically dealing with these issues, I can tell you certainly for any of us in the policy realm that have been working on this for years, it's an amazing moment. But I often tell friends, okay, we've now taken the beach, but Berlin is a long way away. And so it's good to remind ourselves of that. And so my panel, our opening panel this morning is about gender-affirming medicine. And so most of you in this room know what this is, but in the United States, we follow what we might call an extremely expansive and liberal interpretation of a so-called Dutch protocol, which was not a poorly designed study in the Netherlands that had proposed a hypothesis that maybe people as adults, if they were transitioned prior to puberty, would not struggle in the same way as people who transitioned after they went through puberty. So it's effectively a protocol that starts with social transitioning. If the person is at the right age, it moves into puberty-blocking drugs, then cross-sex hormones, and then finally so-called gender-affirming surgery, or might more carefully think of it as sort of sex trait modification surgery. So this is a radical medical intervention. Our panel is quite distinguished and apt to talk about this. So let me just very briefly introduce them and then we'll get to it. First is Dr. Patrick Hunter, who is a pediatrician from Florida and a key figure, though he won't tell you that in this debate. He is also a member of the Board of Medicine for the state of Florida, and he is here speaking on his own behalf and not on the behalf of the board or the state of Florida. Patrick Lappert here as well is a plastic and reconstructive surgeon practicing in Alabama. He has been working in this area and studying this topic for many years as an important spokesman and critic of so-called gender-affirming care. Forrest Smith, who is our detransitioner on the panel, once of Oregon, now I believe from the state of Indiana, and so he speaks from the perspective of someone who received and is now detransitioning from these interventions. And then finally, Dr. Eithan Haim, who is from Texas. He is a general surgeon, and if you've almost all certainly heard his name because he was the whistleblower at the Children's Hospital in Houston. Yeah, absolutely. That was frankly tormented as a whistleblower after he revealed that though the state of Texas had prohibited these procedures in the state, along with now over half of U.S. states, he knew for a fact that the Children's Hospital was still doing that. And so he spoke out. He's one of these people that did what was right, even at the potential loss of his career and reputation. The tide has turned, thankfully, and maybe we'll talk a little bit about that. So with that, I don't want to spend any more time introducing our panel, but I think you'll see that they're precisely the right people to talk about this. So let's welcome our four distinguished panelists. So let's start with Dr. Hunter, Patrick. We've got two Patricks on this panel, so you know, and so I'm wondering, speak a little bit to the fact that lots of professional medical organizations, the American Academy of Pediatrics, in your case, is a pediatrician, activist groups posing as medical organizations like WPATH, the World Professional Association of Transgender Health, continue to speak as if there's a sort of scientific certainty about the benefits of so-called gender-affirming care in medicine. I mean, what do you think it's going to take for them to at least recognize that there's a legitimate debate here? And are you optimistic that'll happen?
I'm not optimistic that they will see the light. They dug in their heels, and they're committed to this. Patient harm, the detransitioners, the first duty a physician has is to not harm their patient. Before you try to do good, you should not harm. And the harm is not causing them to see the light. Two things would motivate them to change, I think. I think financial risks, but the AAP is being sued. Doctors are being sued, but they still persist. Reputational damage may cause them to change. But they need to be exposed and they need to be called. And I think we're here at the Capitol. I think congressional hearings to bring the head of the AAP, the head of WPATH, ask them why they suppressed the evidence, what Alabama exposed. Why did they not allow Johns Hopkins to have academic freedom and publish? Ask these questions. Ask an NIH-funded researcher like Joanna Olson-Kennedy, why are you not publishing your data? Why are you using the suicide narrative to coerce parents and patients into transition? Ask them these questions publicly and make them defend themselves. That will damage their reputation and help save kids.
Dr. Lappert, you've studied this topic in detail as a plastic and reconstructive surgeon. Could you give us a sense of the lifelong effects and potential harms of individuals who undergo this so-called gender-affirming medical transitions?
Well, speaking as a surgeon, I'll address the things that are particular to patients who have had the surgery in the past. So perhaps the most commonly performed surgery today, because of the changing demographic of the self-identified transgender person, is primarily late adolescent to young adult females. The most commonly performed affirmation surgery now is chest masculinization. And chest masculinization is a both sides mastectomy with complete removal of the nipple and then the reapplication of the nipple to the chest. That's an irreversible operation. I've done many breast reconstructions for cancer or congenital deformity, but you don't actually create a breast. So you can create a breast mound, you can create the appearance, a simulacrum of a breast, but they will never be able to breastfeed. And because the most commonly performed operation includes the complete removal and replacement of the nipple, they will never have erotic arousability from the chest. Their chest is essentially numb, other than the kind of sensation you get on your shoulder or on your back. So that's an irreversible thing, lifelong thing. In the case of genital surgery, where what amounts to a genital mutilation, including castration, the removal of the penis, removal of the uterus, vagina, ovaries, and all of that, those are utterly irreversible. And because those operations also involve a lot of surgery on the urinary tract, the end of the urinary tract, these are patients that are prone to urinary obstructions, urinary leakage, loss of control of urine, and things like that. If the surgeries involve the construction of a complete counterfeit phallus, for example, you can have lifelong complications of recurring wounds. And in the case of vaginoplasties, the potential for connections between the counterfeit vagina and the adjacent structures of the bladder and the bowel. So loss of bowel control, leakage, and all these things requiring repeat surgery. So these are patients who have a high likelihood of requiring repeat visits to the surgeon's office, to the hospital, for corrective surgery for any of these problems. And the increased lifetime risk of cancer because of the high dose of cross-sex hormones requires a level of vigilance that they otherwise would not have had. So it consigns them to essentially a lifetime of medical care, in addition to the need for supporting hormone replacement.
So Forrest, we're on the receiving end of this type of intervention for 5 years, if I'm not mistaken. Tell us a bit about that, and especially, from your perspective, what do you think is the most traumatic or damaging part of this thing that you went through?
Yeah, and I'll say that's a bit of a trick question, because although I was on hormones for 5 years and I had three, I count the laser hair removal as a permanent, it's not a surgery, but it's a procedure. But, I gave you the question, what was the worst damage? And for me, just the 5 years that I spent in the ideology and in the identity, the whole lifestyle, the damages that were done to me surgically, they're this objective external thing, but to be the kind of neglect that I would say was going on, when I was pursuing that lifestyle, the other things that I wasn't pursuing as an adult, psychologically developing as a man, when I came out of the transition, I was still lacking those tools for adulthood. And part of this is because the lifestyle was totally supported on public health insurance and public programs. So my housing and my employment and my job, all of that was really covered by transgender activist movements and public social services. And when I came out of that to detransition, of course, I got no coverage and no help. So I was left in a hole. And those 5 years of trans identification and activism, I was digging myself into a hole, and you can't get that time back. And so I think a lot of times the worst damage from the transition wasn't just the physical harms that were done to me, because there are plenty of other men who might suffer from I had a bilateral orchiectomy, so I was lucky I didn't have the vaginoplasty, or else what I'm saying might be different. But there's plenty of men that sustain such injuries, and it doesn't necessarily damage them as much as I think for a detransitioner who goes through these surgeries and goes through these procedures that alter their body so much, and then they realize it was a lie. So now they have to recover, psychologically, they have to reorient their life. They have underlying mental illnesses perhaps, or issues with their family, and they've been hit while they're down also with the medical damages. So the medical damages are almost just like the cherry on the top in a way, in a bad way.
Yeah.
Not a Sunday you want.
Wow. Well, Dr. Haim, this is, a major change of fortunes, I must say, from, if we had been doing this event a year ago. But of course, all of us know about this aptly named executive order that President Trump signed, dealing with, in fact, it specifically has the word mutilation in the title of it. Really blunt and direct, but insofar as the federal government and the president can sign an executive order, at least to try to limit federal funding of these things, it certainly at least gives a major air cover for the efforts in the states. But of course, you directly experienced a state law which prohibited these practices, and then people participating in them anyway. Do you think that things will be different with this executive order and greater scrutiny, or do you distrust many of the practitioners to follow the law?
Yeah, I think we all know the answer to that question. It's like, definitely not. These hospitals are definitely not shutting down these programs, because just like in Texas Children's, there was a template that had arisen, right, where you have a legal threat coming from state authorities. In the case of Texas Children's, it was the governor and the attorney general saying that these interventions could be investigated as child abuse. All right, so that's like the initiating thing. And then the hospital says, we're not doing this anymore. They release some big public statement, we're not doing this because of the potential criminal ramifications, their words exactly. And what they do, 3 days later, they keep on doing the same thing. They continue it and expand it. And that's what I believe is happening now at all of these other hospitals. And it makes sense, too, because these hospitals are so committed to this ideology. If they were to ever self-reflect, they would have to come to terms with the damage that they've done to the people that they said they're caring about the most, which is a reality that is too severe for someone to really come to terms with. So what the other whistleblower in Texas had began to expose is doctors using potentially fraudulent billing codes as a way to bypass scrutiny from state and federal authorities. So what I mean by that is there were a few lawsuits that were filed by Ken Paxton over the past year, 3 of them. And in one against Dr. Cooper, I think he was in El Paso, it was for the violation of SB 14. When you read the lawsuit, it describes the alleged scheme. And what they would do is they would have a patient who would come in, maybe a 16-year-old girl, and because of SB 14 being passed in Texas, it was now illegal. But how could they continue, quote-unquote, gender-affirming care? How could they get these hormones prescribed but still get paid for it? Or the blockers prescribed and still get paid? So what they would do, 16-year-old girl comes into the clinic, right, believes she's a boy. They would change the sex on the medical chart, which is really easy because Epic, which is a big healthcare medical system, has instituted this thing called the Gender and Sexual Identity Smart Form, where anyone can change the sex of the patient. So on the chart, it says male. And then for the diagnosis, they write testosterone deficiency. There may not be any diagnostic evidence of testosterone deficiency, but that's what they list on the code. So when those two things go to the insurance companies, the diagnosis, testosterone deficiency, and then the treatment, the CPT code, which is testosterone supplements. So the 16-year-old girl gets the testosterone paid for right from the pharmacy. The doctor gets paid. The insurance companies or Medicaid or Medicare don't know they're getting scammed. And we all don't know we're getting scammed because we're taxpayers. So that's what I believe is going on at all these hospitals. Because if you Google on your phone, right, gender-affirming care diagnosis codes, the fourth thing you'll find is like the Southern Equality Law Center, right? It's like some activist organization. It's they have all the diagnosis codes you can use to fraudulently bill insurance companies. This is like an online guide for how to commit felony medical fraud and get away with it. It's like an online guide for like cooking meth or explosive devices, but this is like a top Google search. So I think that is the new frontier. But because this information is is identifiable with information we have at hand, because the Do No Harm database, the Stop the Harm database, was using all of this insurance data, ICD codes, doctors, and CPT codes, in order to look at like procedures. If you were to set a certain time, January 20th, 2025, before and after, and look at certain doctors, if there's an increase in a certain number of diagnosis codes, then you can pretty much guarantee you've just identified a healthcare scam.
Wow, and so before we go on, if anyone is watching the live streaming, could screenshot the Southern Poverty Law Center pages that he's talking about. I'm afraid they may suddenly and mysteriously disappear in the next couple of hours. So this is a very insightful diagnosis. Dr. Haim, I'm wondering speak to the fact that we live at this moment in which, for lots of very good reasons, there is a severe lack of trust in the medical profession and in public health in particular. We had COVID, we had the lockdowns, we had all the things and the mandates with the vaccines. And I'm wondering, of course, if you're a pediatrician, you're responsible, for instance, for dispensing vaccines specifically. And patients that might realize, okay, wait, so the same professional society that's advising you to do this, they're the ones that also advise this gender-affirming care. That's not an irrational thought to wonder if that might be a source of justifiable skepticism. I mean, what do you think about gender ideology itself as a contributor to this loss of trust?
There was a Wall Street Journal article last week on how the public has lost trust in the medical profession, and rightfully so. I mean, I will say it, I am embarrassed to be a member of the American Academy of Pediatrics, and I'm embarrassed to be a member of my profession. What we are doing to children is one of the greatest ethical scandals in the history of my profession. When I came out and started speaking publicly, I was afraid what it would do to my practice. It actually has built my practice. Mm-hmm. And when parents come and ask me about vaccines now, and their concerns about those, it's not about MMR causes autism, which it does not. The MMR vaccine does not cause autism. It's not that DTaP causes seizures. That was the issue in the 80s. It does not. I tell them, your concern, it's a general concern. Your concern is that you have lost trust in the profession of medicine. And the fathers go, yes, that's it. And the mothers go, yeah, you've lost trust in my profession. And then I expose myself. I say, please Google me. Please see who I am. And they say, I have. And I say, you know where I stand on gender? And they say, yes. And they say, that's why we trust you. Because our profession is harming people. It has to stop.
So, Dr. Lappert, you mentioned briefly the effects of top surgery, but there's this popular urban legend that top surgery for girls can somehow be reversed. In fact, a prominent gender doctor is online saying exactly this. So say a little bit more about why this is just obviously not true.
Yeah, one of the chief ideologues and proponents of gender affirmation care and gender affirmation surgery, Dr. Olson Kennedy, actually online in a panel said that, well, if girls want their boobies off, they can have them off, and if they want them back on, they can have them back on, which is a remarkable thing for a physician to say, knowing what even the most rudimentary medical education will tell you, that once a breast is removed, the best you can hope for is to create a simulacrum so that the person can dress for the day and not worry about what they look like. But that's not a breast. In the case of men who had been transitioning to the appearance of women, those things are reversible, and I've done reversal surgeries on detransitioners to remove implants and to remove what results from high-dose estrogen dosing in young men. So, but yeah, as I alluded to earlier, once a breast has been removed, the best you can get back is a mound that looks like a breast. But you do not have a breast. You don't ever get the capacity to breastfeed again. And as I alluded to earlier, you have essentially total anesthesia, numbness of the chest as a result of that, because the nerve that is severed that supplies the nipple, that is not reconstructed. That's gone forever. So yeah, it's a lie. And for the leading proponent of these sorts of procedures in the gender affirmation world, a very public figure, to say that is a remarkable thing and sort of speaks to their truthfulness.
There's a woman in here that I know who has a child and cannot breastfeed because her breasts were removed. And for Joanna Olson Kennedy to say you can just go get them put back on, she needs to account for that publicly. She needs to explain to the public what she means by that. More importantly, she needed to explain to patients, to their face, what she meant by that, the patients that she has harmed.
So Forrest, I mean, obviously you were struggling severely with gender dysphoria, or you wouldn't have undertaken or allowed these procedures. Looking back, though, if you say sort of put yourself back at the beginning, how do you wish doctors and the people around you had responded?
Well, I believe that I was struggling with gender dysphoria at the time, but since then I've actually realized that the definition of gender dysphoria given by WPATH is circular logic, and you have to be transgender in order to experience gender dysphoria. So therefore, I didn't really experience gender dysphoria. I experienced something else, which a lot of men have experienced throughout time. We have history going back to the Roman Empire of emperors who wanted to be transsexual, and also poems of young men who castrated themselves for a goddess and then regretted it. That's actually a part of our history. It's very established. If you look back at the 1990s, you have this tome, this textbook called Men Trapped in Men's Body, come out by a self-identified autogynephile transsexual, which is, if you can stomach it, it's hundreds of pages of research on the men who pursue sex reassignment surgery and what's going on in their heads, what's motivating them. Some of them, a lot of them come out of it. I remember reading in that book that the number one reason that men stopped pursuing transsexual surgery was because of love, a romantic interest, a competing heterosexual desire. So my point is that there's a large body of research that psychologists should be referring to, kind of the old school sexologist, etc., should be sitting down with a patient and asking what's going on. And I'm speaking from the male side of things, of there being a sexual motive. Those questions didn't come up in therapy at all. What I received was total affirmation therapy, where nothing was questioned. Everything was simply accepted and suggested to me and kind of sold to me. There's one pathway, and it's surgical transition. What we don't have is serious psychology, sitting down and asking questions about where does this come from, what's underlying this desire, where is that coming from, and that's what I wish I had gone through, is just to have these surgeries and the medical procedures not given to me freely, withheld, and just wait and see. Because if none of this had existed, and if there'd been no sexologists even, or psychologists, and I simply had not been able to pursue this medical path, if it hadn't been there for me, I wouldn't have gone through it. I'm fairly confident that I would have overcome all of this.
So you're saying, I want to just elaborate a bit more, because of course you were struggling, but you also suggested that there was suggestion, not mere affirmation, but sort of coaxing down this pathway. Is that how you would describe it?
Yes, and and so part of that began just online, seeing transgender influencers back in 2015. So my struggle was, in part, I was struggling because something had been introduced to me. I was deliberating something that was actually impossible, right? You're deliberating, can I become a member of the opposite sex? So you're deliberating something that's ultimately impossible. But when I was sort of pushed into that, and I don't need to get into it, I was 19 when I started going down this path, and a lot of it was social pressure from former classmates, right? There were a lot of young men and women from my generation who, although they were very brilliant, also suffered with mental illness or drug addiction, et cetera. And I was pushed into a psych ward. Actually, I got left at a psych ward. I wasn't diagnosed with anything except I was given a transgender roadmap by a social worker there who was queer identified themselves, and it has every operation you can think of related to transgender operations covered by public health insurance. So all along the way, there were social workers, seeing the way that I was dressing, seeing the way that I was presenting, asking me, do you want to be on the wait list for breast implants? If I hesitated, they'd say, well, you'll have a year to make up your mind, and it's free, so why not? Just get on the wait list. Wow. And once you're on the wait list, then the hospital is going to call you and basically solicit these surgeries.
Dr. Lappert,
That part of the real tragedy here is that the affirmation world presents this as something that's proven scientifically, and Forrest's account here sort of shows us what they do. They never present alternatives of care. A treatment guideline is what, for example, the Endocrine Society speaks about, but their treatment guideline offers you one choice, which is not a treatment guideline. It's an encouragement to a particular course of care. A treatment guideline is what you need in order to get proper consent from a patient, that you've presented the alternatives of care. Even if the alternative is, here's one thing we can do, the alternative is to just not do that. But the way they presented it is as if it were a standard of care, like WPATH standard of care. But the problem with the standard of care is that it presumes that the level of evidence is so compelling that to do anything other than what's in the standard of care, it risks harm to the patient. But the standards of care, the WPATH standards of care on the first page says this is not a standard of care, it's a treatment guideline. But as a treatment guideline, it presents no alternatives of care. Wow. And what it does present is utterly unsupported by scientific evidence, which means that all consent documents related to the care that transitioners receive are essentially invalid.
But even more to that, clap for him, please. It's one path, you get on it, they want you to go all the way down it, but they know the evidence does not exist. WPATH hired Johns Hopkins University. Karen Robinson, the lead researcher, sent an email to HHS saying, we found little to no evidence regarding children and adolescents. They still say this is evidence-based. They know they don't have the evidence, but they still push this. It's a scandal.
Dr. Haim, so you a few minutes ago revealed to us the tricks for getting around the legal prohibitions. You have thoughts about, new boss in town here in Washington, D.C., in fact, new bosses at places like DOJ and HHS and presumably NIH. Do you have some thoughts about, given existing policies, how could, say, the DOJ and HHS deal with precisely these kinds of tricks?
Yeah, so I think there's a couple of routes. I think there's a route that the DOJ, HHS can do. There's routes that organizations like Heritage or Do No Harm, they can pursue, and then even individuals. So from the DOJ, all they have to do is look at the insurance data, the diagnosis codes, the doctors around a certain time frame. Because these are federal crimes. Like you go to prison for a long time type of federal crime. And they just have to enforce the law. And especially because every children's hospital in the country, at least 50% of their funding comes from Medicaid. So if they lose that, and the executive order is tied to Medicaid, which is why all these hospitals were so quick to say we're shutting down the program. Because if you threaten Medicaid funding, then the hospitals become insolvent. So what the DOJ has to do is they have to pursue a couple of high-profile cases aggressively, send a few people to prison for violating the law, which is simply what their job is. Because these people are not like hardened cartel members. Like if you send one or two to jail, everyone else is going to get in line, right? Because they're not that intense. So maybe I'm wrong about that, who knows? But
We can test it.
yeah. The second thing, which is one thing that me and a few other people have been pursuing, is so they have these databases, these people who run these databases, and it takes a certain amount of money to get a hold of this information. So you get some wealthy person, right, and then you have some data people. You look at this data, you target, look at which doctors are doing this. Usually they advertise their criminal behavior publicly because they've been getting away with it for so long. So, why would they not advertise it? So it's pretty obvious who the targets are, right? You look at those doctors, privately with this data, and then you give that information to either the DOJ or the Attorney General's office, right? Which may or may not have been how Paxton had done his thing. So, but then also for the individual. So that's like an organization route. Like an organization, a certain amount of money, they can go get this data, use it to then guide law enforcement authorities. Third, so, say you have someone who is living in California, Oregon, Washington. So hospital says that they're not doing this anymore, and Medicaid funding is tied to them not doing it. If you go into one of those clinics, right, someone in this room, for example, goes into one of those clinics and finds out that there are still doctors who are doing it, they can give that information to authorities as well, right? That comes out in the media, then this hospital is going to be under a great amount of scrutiny. They're going to have their Medicaid funding, and the board members of those hospitals are going to freak out because the chance of losing that funding leads to insolvency. So those are three solid routes that the average person can do. And the evidence that these things can work is just look at me and the other TCH whistleblower, Vanessa Sivage, right? Just from both of our stories coming out and what's come after that, there has been material changes in the state of Texas, not only defensive in terms of legislation, but offensive in terms of identifying doctors who are violating state laws.
Wow. So, Dr. Hunter, I know you told me in a conversation a couple of months ago about your experience submitting topics for the 2025 American Academy of Pediatrics Education Conference. I presume in good faith as a member of the society. Tell us a little bit about what became of that.
So this is, I think, my second year I've submitted talks for the AAP's national conference. This year, several people graciously cooperated with me. I submitted a proposal for the European perspective on this issue. And Dr. Rita Katiala from Finland and Dr. Michael Landon from Sweden, both eminent people in this field, were willing to speak to AAP members and come to Denver in the fall. The British perspective was going to be Anna Hutchinson, a psychologist, whistleblower at the Tavistock. She was going to come along with Dr. Juliet Singer, who was a member of the Tavistock Board of Governors, and present what the changes are happening in NHS. And I propose that I moderate a panel of detransitioners. All three were rejected. They do not want to hear this. Patient harm, evidence do not matter. The ideology is what matters to them.
Wow. Dr. Lappert, we've already talked about the effects of so-called top surgery and the inability to truly reconstruct organs once they've been removed. But say a little bit, this is your expertise and it's a difficult topic, but What about so-called bottom surgery for males and females? Once it's done, can some things be undone? I mean, what's the situation for people dealing with that?
Well, generally, once the genital surgery, what's called euphemistically bottom surgery, is done, those are irreversible things. You cannot reverse a castration. You cannot reverse oophorectomy, removal of the ovaries. You can't restore a uterus, although people are experimenting with that right now. So generally, what the surgical assistance to detransitioners involves managing the complications of what they've had done in the past. So these operations involve surgeries in the pelvis, in the proximity of the rectum and the bladder, and very often the difficulties that these patients get into is that the construct communicates with bladder and rectum. So generally, surgeries that are done after the fact are aimed at correcting these problems of what are called urinary fistulas, fecal fistulas, urinary obstruction, the results of urinary obstruction, kidney injuries, and things like that. So surgery is essentially management of chronic wounds and chronic problems, but there's no way to reverse genital mutilation. I did corrective surgery for genital mutilation in the combat setting, but there what you're doing is the patient arrives with the wound. In this case, the patient was wounded by the medical profession, and all that's left to be offered at that point is things to manage the complications.
And to give people an idea of like what that means, like when they talk about like a fecal fistula or urinary fistula, I mean, I was operating 2 weeks ago on some guy who had something called diverticulitis, right? Inflammation of the colon. You know, that forms a fistula to the bladder. So in the cases of these operations, what's happening is they're pouring out stool when they urinate every single time. Like that's what's happening to these people. And just imagine living your life like that.
Forrest, I know I've talked to many detransitioners who have observed that, at least in their case, they felt like the path to transition became a sort of camouflage or replacement for dealing with other so-called comorbidities. And in fact, that is other struggles alongside maybe gender dysphoria and discomfort with their bodies. Was that the case with you?
Yes, and those remain, unresolved when you come out of transition, and a lot of times exacerbated. But there's something I kind of wanted to sidetrack to, just as I'm thinking about some stories of with the doctors that I was actually talking to our friends here about today is just the issue with the guilt of some of these doctors, because in my story I've actually several times felt like a confessor to some of the doctors who would go on to operate on me. And one surgeon who was giving me a consult for the vaginoplasty, which I didn't go through with, was actually on the point of tears as she showed me pictures of the men that she had operated on. And these were patients who were operated on through Medicaid. So these are two separate stories and surgeons. With the breast implants, I had gone in and tried to cancel. And when I went in and told the surgeon that I wasn't going to go through with the surgery, he told me, "You're making the right choice."
Wow.
And then he went on to tell me, he said, many of my trans female patients who come in on public insurance are making a mistake. And he described being able to count their ribs, because he was telling me how emaciated they were, because he was literally operating on homeless people. Wow. And in Portland, some of the situation with the homelessness is the homeless aren't like native Oregonians, right? They're not from Oregon. They are getting shipped there from all over the country. So these people are totally homeless and destitute, and then they're being operated on. And they're having these vaginoplasties, which it's hard to call them vaginoplasty because it's just this gross mutilation. And so I was talking to a surgeon, and she's showing me picture after picture of her patients, and they're horrible pictures to look at. They're just horrible mutilation. And that's when she's like, her eyes are watering as she's presenting this to me, and she's kind of trying to tell me it might not turn out right. And at that point, I was also so thoroughly into into the identity and the comorbidities. I was struggling with addiction, so it was during COVID. I was wearing a little mask. I had no eyebrows, wearing a soggy hat. I also was a waif. And I told her what I had heard from some of my transgender friends. I said that I realize I am a guinea pig, because she was telling me we don't have enough data. She was saying, we don't have enough data. We don't have enough experience. I said, I realize I'm a guinea pig. And then she told me, that's very insightful of you. So these doctors, the better ones, right, have to realize, and the guilt is like leaking. Wow. And the surgeons we're dropping very vulnerable people with huge wounds back into deplorable situations. Like when you hear the United States is doing this to like people in Guatemala, that kind of situation is somebody who's very, very privileged would be suffering.
And if you have a surgeon who's telling a patient that, like, yeah, you are a guinea pig, like, that person is not a surgeon, they're a butcher, right?
Just almost out of time, but the other physicians want to just say last words.
I think that's one of the groups we need to reach out to, is the young physicians who have been dragged into this unknowingly. When you go off to medical school, you have ideals, you want to do the good for people, and you sort of fall into the guidance of senior physicians and surgeons, and you're sort of you're an easy mark to be led into this world of medicine and surgery, that you're too busy to examine the data. You have your call schedule, the patient load is just more than you can bear, and very often it isn't until after you graduate that you take a breath and you go, what have I been doing here?
Wow.
And so these are people that we need to reach out to, just as we reach out to parents who have been unwittingly drawn into this, because they are wounded in their own peculiar way. Certainly not to the degree that the medical and surgical patients are, but they are victims in their own peculiar way. We need to reach out to them.
Absolutely. Well, we're out of time. Let's thank our panel.